Okay, good afternoon, folks. This afternoon, topic B talks about CMS is launching or has launched its first rural health transformation projects. Now it's a program to help communities with um, rural health problems. Now finding doctors that'll go out to rural clinics, rural hospitals, keeping those going. So that is what CMS is trying to do. Okay. So we're going to discuss that for B. Please join me in today's presentation I made for you. Let's get going. The state has launched its first State of Rural Health Transformation RHT projects, 25 initiatives funded with initial 36 million to reopen clinics, modernize infrastructure, expand telehealth, and close long-standing technology gaps. These awards mark the state's entry into the federal government's 5-year, $50 billion effort to rebuild rural healthcare. A deeper look at what the state just did. State health officials approved 25 projects across rural and frontier communities, each designed to tackle a specific barrier. Shuttered clinics, outdated equipment, insufficient diagnostic capacity, or the absence of basic digital infrastructure. The reopening of the Tonopah Rural Health Clinic among the most symbolic early wins, a community regaining its own local access point for primary care after years of closure. Other funded efforts include emergency medical services upgrades in West Wendover, 3 new clinics emerge Esmeralda County to address severe provider shortages. Retinal imaging equipment for the Fallon Showstone Tribal to expand chronic disease management. A mobile dental clinic serving Lyon and Stony counties bringing preventative care directly to residents who often travel hours for basic services. These projects fall under the state's Rural Health Flex Fund, the first of 4 RHT funding streams focused on one-time infrastructure and technology investments. How this fits into the national RHT program, the Federal Rural Health Transformation Program, created under the Working Families Tax Cuts legislation, is a $50 billion national investment intended to reverse decades of rural health system decline. All 50 states applied, and each approved state receives a baseline share of the funding with additional dollars awarded through amendment review hhs.gov. The program's strategic goals include expanding access through new clinics, mobile units, and preventative care models, strengthening the rural workforce, including recruitment and retention strategies, modernizing technology from telehealth to data sharing systems, testing new care models that improve outcomes while lowering costs. Why this first round matters. These early projects are not just symbolic. They are capacity building investments that determine whether rural communities can participate in later, larger phases of the program. The federal government has made clear that future allocations depend on measurable progress. And the CMS has already rejected some state proposals that didn't meet program standards. For rural communities, the stakes are high. Distance is destiny. Long travel times suppress preventative care, worsen chronic disease outcomes, and increase avoidable hospitalizations. Infrastructure is destiny. Without broadband, diagnostic equipment, or basic clinic space. No workforce strategy can succeed. Momentum is fragile. Small clinics often lack grant management capacity. Making early technical assistance essential. Risks and structure challenges. Funding gaps remain. Nevada's allocation is among the lowest nationally, and even with federal support, the state could still face hundreds of millions in Medicaid cuts over the next decade. High demand. The state received far more applications, and it could fund, underscoring the scale of unmet needs. Workforce shortages. Roughly 40% of future RHT dollars are expected to target provider recruitment, but CMS has already rejected some loan repayment. Proposals signaling tight federal control. What to watch next? Second round awards later this year, likely focused on workforce and care delivery innovation. CMS performance reviews, which will determine whether states retain or lose funding. Local implementation speed, especially for projects requiring construction equipment, procurement of new staffing models. CMS has now pushed first year rural health transformation RHT dollars to every state, a historic all states at once infusion. But the real story is how unevenly those dollars are moving through state systems. Some states are already signing sub-grant agreements with rural clinics. Others are still drafting RFAs. A few are quietly revising plans after CMS flagged compliance issues. The money is out the door, but the transformation is not yet evenly underway. The national funding picture, what the numbers actually show. The federal government released FY 2026 baseline merit awards to all 50 states, with totals shaped by population royalty and the strength of each state's application. The range is wide, roughly 147 million to 281 million, with an average near 200 million. But the variation tells a deeper story. About rural need, state capacity, and CMS has early signals about program direction. High award states: Texas, Alaska, California, Montana tend to have large rural geographies, high frontier populations, or strong merit review scores. Mid-range states: Pennsylvania, Colorado, Iowa often proposed balanced plans, emphasizing workforce access and infrastructure. Low award states: New Jersey, Rhode Island, Connecticut have smaller rural footprints, but still face steep access gaps. What matters most is not the award amount, but it's how fast states can convert federal dollars into rural access, workforce, and infrastructure gains. The four procurement lanes states are falling into across the country. States are clustering into four recognizable stages. These stages are not cosmetic. They determine whether rural communities see benefits in months or years. In development, states are still drafting RFAs, building scoring building scoring plan rubrics, or revising plans after CMS feedback. These states risk losing early momentum and may struggle with provider frustration. Posted and open. RFAs are live, and rural providers can apply. This is where Pennsylvania sits. Multiple funding streams posted, with more expected. In review, applications are submitted under evaluation. These states tend to have stronger grant management infrastructure and clearer scoring criteria. Agreement awarded. Subgrants subgrants are signed. Money is flowing to clinics, EMS agencies, tribal health programs, and rural hospitals. Montana, Nebraska, and Delaware are early examples. Small but nimble states that moved quickly. What this means for rural communities. The RHT program is designed to be performance driven, not just grant driven. States that move quickly and document measurable improvements in access, workforce stability, and infrastructure will be better positioned for future merit based allocations. Slow moving states face three risks. Delayed impact in communities already struggling with closures and long travel distances, loss of provider trust, especially in regions with fragile clinic networks. Federal scrutiny, including required plan revisions or, in extreme cases, clawbacks. What most What's most useful for you next? States risk losing rural health transformation dollars whenever they fall out of alignment with the commitments they made to CMS, and the agency designed the program so that clawbacks are not theoretical but a central enforcement tool. The RHT program is built on cooperative agreements, not passive grants, which means CMS can intervene, redirect, pause, or fully rescind funds if states' performance reporting or policy exclusion slips. This is the backbone of the program's accountability architecture, why clawbacks exist, and why CMS is using them. The RHT program is the largest rural health investment in U.S. history, and CMS has been explicit. The money is conditional. Cooperative agreements give the federal government the same kind of leverage it uses in Medicaid waivers, ongoing oversight. Required milestones and authority to take money back if states drift from their approved plans. CMS leaders have said publicly that clawbacks are meant to prevent states from treating RHT as a windfall and instead ensure they deliver measurable improvements in access, workforce stability, technology, modernization, and care models innovation. In other words, the dollars are tied to transformation, not maintenance. The specific triggers that can cause a clawback. The technical score. CMS's annual performance grade. Every year, CMS calculates a technical score for each state. This score blends data-driven matrix exclusions, how well initiatives are implemented, policy follow-through, reporting quality, timeless competence and accuracy. A low technical score doesn't just reduce failure awards, it can trigger retroactive clawbacks of funds already distributed. States must meet many of their foundational commitments by the end of 2027, making the next 18 to 24 months the highest risk period. Okay, guys, that's your B for today. I will be back on with C in a bit. For now, Gator Wellness, take care, folks.